My talk this morning is the things that we can do to empower our patients and ensure that they have the best possible outcome when they have breast cancer. So, and for that, as an introduction, if we think about breast cancer over the millennia, it started off obviously in the thousands of years ago. The first description of breast cancer was sort of in an Egyptian tablet of a woman that had this growth, obviously, in her breast. Now, they didn't understand what cancer was. In their mind, very much it was some sort of vague, mysterious thing that happened to people. And if you look at sort of 3,500 years ago, so over all the millennia, there's very little progress that was made in the understanding of cancer. Then we get sort of to the 1500s to the 1700s, and there was a little bit of development. Anatomy was starting to become an issue. They understood that things are not just due to the four humors in the body. They started understanding a little bit of physiology, but they really didn't understand what a cancer was, why people developed cancer, and the mortality rate of breast cancer in this whole time sort of remained close to 100%. The only patients that survived were those that thought they had cancer, but in fact it was something else. And it was sort of only in the 18 to 1900s, actually sort of in the late 1900s, that mortality rate started shifting a little bit. And I think the biggest impact was when they understood that you could actually operate on a cancer, and that cancer wasn't just a local, you couldn't sort of just peel out the lump. You needed to make sure that you get around the tumor. So Halstead famously presented this idea that cancer isn't something that is just local, it's something that is regional, and if you could just sort of do the biggest operation possible, then you could actually get around the cancer. But he understood very well that you can't sort of peel the cancer out. And the famous quote from him was that the one who extirpates the cancer should be the arch enemy of the one that tries to close the wound. So that was the purpose, and I want us to remember that, because somehow it feels like we are going back to that a little bit in many aspects as we've gone along. So in the 1900s, that's really where a lot of the development, that's where we made the biggest shift in terms of cancer mortality for breast cancer for patients, where most of the understanding started happening. And I think things like radiotherapy started coming along. At first it was almost as an alternative to surgery, and needless to say, the radiotherapy that we're talking about then was completely different from what we have now. But slowly we started understanding that it's about the package that you give the patient and not about the surgery. And Bernard Fisher came and said, well, maybe we don't have to do a mastectomy, maybe we can do breast conservation. So the mortality rate came down to about 25%. And then in the 2000s, I think we started understanding the biology of the cancer a lot better. We started looking at targeting specific things, anti-HER2 therapy, looking at different anti-estrogen therapies. And for the past 25 years, every year, there's been a 1% reduction in breast cancer mortality. So, without exception, we've been able to get that mortality rate down to now between 5 and 10% on average. Obviously, the earlier stage the patient has, the better that outcome. So, if we look at all this time we've spent from, the era of no understanding to really getting an idea of what we're doing to where we are now, I definitely never want to say, well, we've now come full circle where we are doing mastectomies for everyone again. Okay, so that's my introduction, and the question is, how do we ensure that we give the patient all these hundreds of years of development so that she has the benefit of that today? there's no sense in us treating a breast cancer and she has the same outcome as she would have had in 1975. So I'm going to talk a little bit about how we can impact risk factors, talking about diagnostic dilemmas, access to care, and then just a little bit about survivorship. I think those are the 4 things. So in terms of risk, I think a very important part for me always to understand or to tell people is that, remember one thing, as the breast develops, now boys and girls both have a breast bud, but then during puberty, obviously, with estrogen stimulation, that breast bud starts developing into a breast. But that breast remains immature until that little girl holds her first baby in her arms. So even if she has a pregnancy at 30 weeks or at 25 weeks and she loses that pregnancy, that breast does not mature. And that process is supposed to happen under 30. That's why having children under 30 has a protective effect on breast cancer. Now, anything that you do in that phase of your development is going to have a 50 to 100% increase in the effect of that risk factor. And I think that's an important part to understand, because a lot of the research that we do on breast cancer and what causes breast cancer and why people get breast cancer are things that are done on adults, and especially on women that's already had children. So a lot of what we think of breast cancer really doesn't have anything to do with this. And the question I frequently get is, why are we seeing so many young patients? I don't even blink if I see a patient in her 30s with breast cancer. It's not an uncommon finding. But it should be a big red light. Why do you get breast cancer at 32? And part of that is because we've forgotten about this. And we are exposing little girls to things that are going to give them breast cancer at 35. Okay, so there are lots of things that play a role in terms of what contributes to breast cancer. Breast cancer is a multifactorial thing. The one thing that I want to add up here is, and I don't want to use stress as a really bad term, but let's say the stress of being placed in a corporate environment. For example, a female person that is a lawyer has about a 2.5% increased risk of getting breast cancer versus the same person that is a teacher. So if you're working in a very high-powered professional capacity where we are constantly bombarded. I mean, I think I would also get cancer if other lawyers wrote me nasty letters the whole day. But anyway, But I think there are a lot of things that we can't change. I can't change the fact that that young girl wants to grow up and be a lawyer. Okay, but I do have a few things that me as a healthcare professional can impact on. I can't change a gene mutation, but I can think about it and I can test for it. So Chantal is going to talk to us about genetic testing and where it should be done appropriately. That is a very neglected. Last night I gave a talk at a women's fundraiser event. There was probably about 110 women. I had 5 of them come to me and say, you know, Doctor, I had breast cancer 15 years ago. I was 35. No one's done genetic testing on that patient. So a lot of our patients that I'm seeing for thyroid nodules, parathyroids, I always ask them, who in your family has ovarian cancer? So we need to be, if we don't flag this, the gene is not going to stick its hand up and say, please test me. Okay. Number 2 is what we are doing in terms of exposing patients to endocrine environment. Now, I'm not worried. I want to clearly say, I think HRT, everybody's worried about that. In principle, HRT does not increase breast cancer risk. The amount it does is negligible. Oral contraceptives in patients who've had babies before, not a problem. Oral contraceptives in young girls that have not had a baby, definitely a problem. It increases the risk for breast cancer by up to 20% if they use it for longer than 5 years. And I always say the pill was not developed for pimples. But if you talk to teenagers, how many of those girls are on the pill from 13 or 14 years of age until they are getting a baby at 35? That is a big issue in terms of exposure to prolonged endocrine environment things. I'll talk a little bit about intrauterine devices. And then I think the other thing that we can definitely be advocates for is alcohol use. We live in the Western Cape. When I speak to one of the psychiatrists, they say, we probably have about 40% of people staying in, let's say, Durbanville that are, by definition, alcoholics. So the amount of alcohol being consumed by our patients are massive. But we don't spend time educating our patients in terms of the harms of it. If you, WHO, asbestos, smoking, alcohol, all in the same class of carcinogens. Okay, you don't tell the patient to put asbestos in their ceiling for insulation anymore. But we are very happy to allow, to encourage them even to have a glass of wine or have whiskey or whatever. So, how much is a unit of alcohol? 76 milliliters of, I don't know what standard wine is. In the Cape we don't have standard wine, we have box wine and we have whatever. But anyway, standard wine. There are very few people that measure their wine in tots, but anyway, but to give you an idea, so if you have an average risk woman, and in our population it's about 1 in 10 patients, then you're going to find that if they take 3 units of alcohol, in other words, if she has every day, let's say 170 mils of alcohol, we're going to see 5 extra breast cancer cases. It's not a huge amount, it's a bit of a shift. But once you start upping that to 2 glasses of wine per day, now it goes to 27 extra patients per 1,000 women. Now it becomes a little bit more of more of a blip on the radar if you look at all the little red dots there. And once the patient starts going to above 6 units a day, now we actually almost tripling the amount of cases that we're seeing, 70 extra breast cancer cases per 1,000 women. So, message number 1, alcohol is a very specific carcinogen. It's not a health choice. I always tell my patients, if you are in the habit of trying to make good choices about your lifestyle, alcohol is not one of them. I get a question a lot about intrauterine devices that have progesterone or Mirena is the typical one that you think about, and it's a little bit like the tobacco industry that tried to crush the idea that cigarettes causes cancer for a very long period of time. These companies have spent millions of dollars flying out experts to come and convince people that they don't have to worry, but there are more than 10 studies that have looked at this, and there's no doubt that this increases breast cancer risk. Again, I always say everything in life costs you something, and you have to ask yourself, is what I'm getting worth the cost? I'm happy to say that this increases my risk by 20%. It means if my risk is 10%, it's going to become 12%, but at least I don't menstruate for 5 years. Maybe I'm willing to sacrifice that 2% of getting breast cancer for that comfort. If you have a second Mirena, it's going to be 43% increase. So the question you have to ask yourself is, what am I willing to sacrifice for the comfort? It's a different issue if you've got a medical condition and this will, if you can save someone from having a blood transfusion because she's got this in, by all means. But calculate the cost. It's not just a comfort choice or an easy choice, and if we don't tell patients about the risks, then we are disingenuous about caring for the patient. Okay. I want to move on to diagnostics. I think the first thing I want to say is mammography is still the standard of care and the gold standard for the diagnosis and screening of breast cancer with a clinical exam. A mammogram should not be done alone. It should always be accompanied. So if my patients say, Dr. Myburgh, I've gone for my mammogram, I say, fantastic, you've done 90% of it, but you still need to have a clinical exam of your breast because mammograms will miss 10% of breast cancers. Okay. So, what is important about mammography is it's not all equal. We are living in an age where a patient should have a digital mammogram. The patient who has dense breast tissue should have a tomosynthesis. Tomosynthesis allows me to pan through that breast and identify. Now you can see on this image, you can see there's a very clear mass there. But if you, as you pan through the breast, it becomes, this one almost you wouldn't see it at all. So tomosynthesis should be part of the mammography toolbox that your unit uses. If you are sending your patient for a mammogram, you make sure that they go to a place where they can access this. Okay. They don't need MRIs and fancy things, they need a tomosynthesis. If patients access mammography, you are going to pick up things like microcalcifications. So, and the problem always with that is, the one thing I want to say is, calcifications are not to be followed up. You either decide there's calcifications and the patient needs a biopsy of that, or you decide there's a reason, let's say the patient had a previous operation, it looks like fat necrosis, then we're going to ignore it. But you're not to follow up microcalcifications, there's no benefit in that. Okay, so that would be my second important message about mammography. Then, the diagnosis of breast cancer is an unpleasant affair. You must make sure that where you send your patient, the quality control must be of such that the patient will have one attempt and it will be a successful attempt. The worst thing is for me to see a patient who's gone through a vacuum biopsy, been a very traumatic experience, and now I have to tell her, yes, your result came back as not cancer, but I can't trust that result, we have to do a second biopsy. So, the quality control of interventional mammographers should be excellent. It should be a unit that does a lot of it. The unit we use most of the time, SCP, centralizes all the biopsies so that the quality control can be there. When they do a biopsy, I would say, you have to decide, they have to have the option of vacuum-assisted biopsy versus core. Now, vacuum-assisted means that they're using a very thick needle. It's an 8-gauge needle. It's as thick as your pen's, front end. So it's a thick needle. It'll aspirate about 1 centimeter worth of tissue. So if you've got those calcifications, this is what you need to do. So very small tumors and calcs, vacuum-assisted. If it's a big lump, core needle. You can't do a core needle on small little things. Okay. They need to do an X-ray of this. And once they've finished, they need to put a little marker into the space where they've done the biopsy so that I can see next year, is this the same thing that was biopsied last year? So that marker allows me to target that area if I want to go and do surgery. So if you send your patient for a biopsy, you ask the unit, do you have the option of vacuum-assisted biopsy? Please put a marker in for every biopsy you do. Do you have tomosynthesis? If your unit can't do those things, then they are not appropriately equipped to deal with modern breast cancer patients. Okay. Pathology, we all know that ductal cancers make up 80% of our caseload, but progressively we are looking into little details within that has become very important. So it's very nice to do a biopsy and send it to a pathologist that gives you a result 4 hours later or the next morning. But if I get that patient and I tell them they have cancer and then that result is wrong, that is a huge problem. So again, pathology is something that requires a team of people that does a lot of it and that is part of a cancer team so that there's accountability for what they do. If I have to choose between accuracy and speed, I will always choose accuracy, and I think that's the important part for me in terms of the pathology of breast cancer. We are very fortunate, I think, with Guillaume and the team at PathCare. They join our breast cancer meeting once a week. We have good interaction with them, and that gives me the confidence that when I'm telling a patient this is how we're going to treat you, I'm doing it based on really good information. So I think that'd be a good relationship. The next level is sort of molecular analysis, and again, a lot of these things have to be sent overseas. It's not easily accessible. You don't have to worry a little bit about that, but if you are sending your patient to a unit that looks after your breast cancer patient, the question is, do they have access to this type of thing? because it plays an important role. There is a group of patients, about 60%, that we can avoid chemotherapy if we employ things like this, for example. So we do not just say, oh well, let's just, just for the sake of it, let's give you some chemo. We want to make sure that when we do something, that we are going to give the patient a benefit for that. All right. So let me come to the when I typed in, I'm not sure how many of you use Perplexity to look at research data and whatever, and I said, what would be the 5 top things that have improved breast cancer care the most in the last 25 years? And number 1 is multidisciplinary breast cancer care. So the difference between sending your patient to your golf buddy who's a surgeon, that person doing something, then sending the patient to the oncologist, that is 1985. This has made a bigger difference in the survival of patients than chemotherapy might. So, mortality rate, if the patient is treated within a high volume multidisciplinary team, 18% less. When Taxotere was registered for breast cancer, it had a 3.5% absolute survival benefit for the patients. And we changed chemotherapy based on that data. When we added chemotherapy as an adjuvant, it decreased the mortality rate by 15%. So your choice of team has a bigger impact on your patient's survival than whether she gets chemo or not. Okay. 5-year recurrence-free survival, 13% less. Why? Because if you do good breast cancer surgery and do treatment, they shouldn't come back as much. The chance of receiving optimal care, if you send the patient to a cohesive team, 25% better. So 1 in 4 patients get the wrong treatment if they are treated in a fractionated way. So I can't stress this enough, is where you send your patient should be a group or a team of people that work together in a cohesive manner, because the treatment of breast cancer is not like it used to be in 1975, where people had surgery, then chemotherapy, then radiation, then endocrine therapy. Now we are in an era where the sequence of how we do things are not the same anymore. We need to see what is this patient's cancer, what is her lifestyle, what is her breast, and then we'll swap things around. If a patient needs chemo, that chemo probably should be given up front. If the patient has an endocrine positive cancer, the patient should have endocrine exposure up front. So we're no longer sticking to this routine. In the old days, the surgeon was the one that did the cancer surgery, and then he would send the result to the oncologist, and then they would sort of, let's do something now. No. Now we want to understand the biology and the response of our treatment, and based on that, we want to adjust our treatment. That can only happen if you work in a team. Okay. Now, that's why I want to come back to this. We started off in 1894 with this. The mastectomy rate was steadily declining, and now in the last 15 years we are seeing an uptake in mastectomy rates. Why? Because the woman comes to me and says, you know what? My doctor said if it was his wife, he would just have a bilateral mastectomy. So there's an emotional and a social media and an opinion-driven thrust for women to have operations like this. I have a patient that says, I had a 1 centimeter cancer, but Dr. X told me the best is to have a mastectomy and an axillary dissection. That is criminal in my mind. If your surgeon that you use does a mastectomy and a 1 centimeter tumor, you should not receive a patient of yours anymore. I may offend some people, but that, I think, should not be happening to patients who have breast cancer. Okay. So, there is no doubt that at 10 years and 20 years, breast conservation, if you can choose between breast conservation and mastectomy. I'm not talking about someone that has 10 cancers in her breast. If you have a 1.5 or a 2 centimeter tumor, if you have a choice between the two, the overall survival is better if you choose breast conservation. So if a patient asks me, Dr. Myburgh, what is the best cancer treatment? Then I say breast conservation as part of your package is the best cancer treatment. Okay. Please do not tell people that mastectomy is better than that. That is academically untrue. So the problem is we are seeing an uptick in mastectomies. There's a little bit to do with genetics, which is a sensible one, but a lot of it is driven by emotion and driven by wrong information, and we are the people that need to change that perception in patients' minds. The same with the axilla. In our unit, probably less than 3% of the patients end up getting an axillary dissection, because we spend a lot of time in de-escalating the patient's treatment and de-escalating the cancer, giving chemo, giving endocrine therapy, doing sentinel nodes. Definitely, again, if there's a unit that is doing a lot of axillary dissections, you are harming a lot of patients unnecessarily without any survival benefit to those patients. My last little bit is in terms of survivorship. We have patients that are surviving longer, and they are going to come to you and they are going to be complaining a lot about a lot of side effects that they have. I think Andre will talk a little bit about how do we deal with some of those things. So this is a big challenge of how do you empower your patient so that she's not a cancer sufferer, not a survivor, but that she can actually thrive and have a normal life after cancer, because we are going to see more and more of these patients. And it's our responsibility to ensure that their bone density is being checked, that their vaginal dryness is sorted out, that that we check the things, because they will survive their breast cancer if we do our job. That is how we empower our patients. That's my story for the morning.